Imagine you're at a restaurant, right?
Mm.
And someone nearby is having a severe, life-threatening allergic reaction.
Oh, like a peanut allergy or something.
Yeah, exactly. Their throat is swelling, their blood pressure is just plummeting, and they're going into anaphylactic shock.
Right. A terrifying situation.
Completely. So to save their life, a paramedic rushes in and injects them with an EpiPen, which is just a massive dose of adrenaline.
Which is standard protocol, yeah.
Right. Normally, that adrenaline would cause their blood vessels to just instantly clamp down, shooting their blood pressure back up to safe levels and, saving them. And this is the crazy part. In this specific scenario, the exact opposite happens.
Yeah, the pressure drops.
Yes. The moment the adrenaline hits their system, their blood pressure drops even faster.
Which sounds like a complete medical impossibility, right? Because adrenaline is supposed to be your body's ultimate biological panic button. It's supposed to prime you for survival. But in that specific scenario you just described, the body's normal response has been completely hijacked by this microscopic blockade.
And that bizarre, counterintuitive medical mystery is exactly what we are unraveling today.
It's a great topic.
We are jumping right into a deep dive on a fascinating stack of pharmacological sources all about the body's biological mute buttons.
Mute buttons, I like that. Medically, they're called sympatholytic agents or adrenergic antagonists.
Right. These are the chemical tools that literally intercept your body's constant fight-or-flight signals. And they use them to treat just a massive range of conditions, from severe high blood pressure to chronic heart failure, migraines, even like totally unexpected stuff like glaucoma and prostate enlargement.
It really is. It's just a masterclass in how interconnected the human body is.
Yeah.
But to understand what these drugs are actually doing, we kind of have to understand your body's baseline first.
Set the stage for us.
Okay, so your nervous system is constantly talking to your organs using chemical messengers. These are endogenous catecholamines, which is just a fancy way of saying molecules you already know, like epinephrine and norepinephrine.
Adrenaline and noradrenaline.
Exactly. So they flow through the bloodstream and they lock into these very specific docking stations on your cells called adrenoceptors. And these are basically divided into two main camps. You've got your alpha receptors and your beta receptors.
Right. And when adrenaline locks into those receptors, it triggers the reaction. The heart races, the blood vessels tighten, your pupils get huge.
Yeah, total panic mode.
But the drugs we're looking at today, the antagonists, they are essentially microscopic bouncers at a very exclusive cellular nightclub.
That is a perfect analogy.
Like the cell is the club, the receptor is the VIP seat, and the adrenaline molecules are just these unruly guests trying to start a mosh pit.
Yeah, they want to tear the place up.
Exactly.
Yep.
So these antagonist drugs just walk in, they sit down in the VIP seat, and they do absolutely nothing.
Right. They don't order drinks. They don't dance.
Nothing. But just by occupying this space, they completely prevent the unruly adrenaline from sitting down and starting a riot.
That is exactly the mechanism. By just sitting there, occupying the receptor space, these drugs prevent the usual intracellular effects. And what's truly amazing is how specific they can be,
How so?
Well, depending on which specific club they're bouncing at, like the blood vessels, the heart muscle, the lungs, they completely change how the entire human system functions.
So the sources explain that alpha blockers basically open the pipes, but doing that causes the heart to panic.
Right. It's a balancing act.
So how do doctors fix one without breaking the other? I guess let's start with the pipes.
Perfect place to start. So let's look at the alpha blockers. Normal sympathetic control of your blood vessels, your vascular system, relies really heavily on alpha-adrenergic receptors.
Okay.
When adrenaline hits an alpha receptor on a blood vessel, it tells the smooth muscles in the vessel wall to squeeze tight. Vasoconstriction.
So it's like kinking a garden hose. The pressure inside the hose shoots way up.
Precisely. So if we introduce an alpha blocker, our microscopic bouncer, we block that squeeze signal.
The hose unkinks.
Right. The smooth muscles relax, the blood vessels widen, which is vasodilation, the kink is released, your peripheral vascular resistance plummets, and your overall blood pressure just goes down.
But reading through these sources, I realized that not all bouncers act the same way, right? It's kind of like a microscopic game of musical chairs, and the rules completely change depending on the drug.
Oh, absolutely.
Like you have a medication like phentolamine, which is a competitive blocker. It sits in the VIP chair, but only temporarily. for like a few hours, maybe?
Yeah, it's easily distracted.
Right. If a massive flood of adrenaline suddenly rushes the club, the adrenaline can actually bump the phentolamine out of the seat and just take over again.
It can.
But then there is phenoxybenzamine.
Oh, yeah. Phenoxybenzamine operates on a totally different level. It is a non-competitive antagonist. It forms an irreversible covalent bond with the alpha receptor.
So it doesn't just sit in the chair. It brings, like, industrial-strength superglue and permanently attaches itself to the seat.
That is literally what happens on a molecular level. It's completely irreversible. No matter how much adrenaline floods the system, it cannot budge that drug. It is permanently locked out.
Wait, so how does your body ever recover from that? If the receptor is glued shut, how do you ever regain normal blood pressure control?
Well, the body actually has to physically build an entirely new club.
What? Really?
Yeah, it has to synthesize completely new adrenoceptors from scratch to replace the blocked ones. And that cellular manufacturing process takes time, usually a day or even longer.
Wow.
So a single dose of phenoxybenzamine has this profound, incredibly long-lasting effect just because you're waiting for new proteins to be built.
That seems like an incredibly heavy-duty, like almost nuclear option just to put the brakes on the vascular system. Why would a doctor ever need to permanently glue a receptor shut like that?
Well, you wouldn't use it for standard everyday high blood pressure. That would be overkill. It's reserved for a very critical, highly volatile condition called a pheochromocytoma.
A pheochromocytoma.
Yeah, it's a rare catecholamine-secreting tumor usually found on the adrenal gland.
Okay, so what does it do?
Imagine a tumor that acts like a rogue, broken adrenaline pump. It sporadically just floods the patient's body with massive toxic levels of epinephrine.
Oh, man. So their blood pressure must just be completely off the charts. They're essentially living in a state of constant maximum physiological panic.
Exactly. And the most dangerous moment for these patients is actually when they go into surgery to have that tumor removed.
Because they have to touch it.
Right. When the surgeon physically manipulates the tumor to extract it, the tumor can act like a sponge being squeezed, dumping a lethal tidal wave of adrenaline directly into the bloodstream.
Which would cause an immediate fatal stroke or heart attack right on the operating table.
Right. So, to prevent that hypertensive crisis, doctors pre-treat the patient with phenoxybenzamine.
Oh, the superglue.
Yes. By supergluing all the vascular alpha receptors shut beforehand, it literally doesn't matter how much adrenaline the tumor dumps during surgery. The receptors are blocked, and the patient's blood vessels just remain relaxed and safe.
That is incredible. And, this actually brings us right back to our opening hook, the EpiPen paradox.
Yes, the epinephrine reversal.
Right. The sources call it epinephrine reversal.
Mm-hmm.
If a patient is pre-treated with an alpha blocker like phenoxybenzamine and you inject them with epinephrine, their blood pressure doesn't go up. It crashes. Explain the mechanics of that, because it totally blew my mind.
It's a beautiful demonstration of how the body balances conflicting signals. Think of epinephrine as a master key that can unlock two different doors simultaneously.
Okay.
It hits alpha receptors, which cause intense vasoconstriction. The pipes tighten, pressure goes up.
Right.
But it also simultaneously hits beta-2 receptors in the skeletal muscles, which cause vasodilation. The pipes widen, pressure goes down.
Wait, so adrenaline is pushing the gas and the brake pedal on blood pressure at the exact same time?
It is. But under normal circumstances, the alpha effect, the tightening, is much stronger. The alpha effect completely overpowers the beta-2 effect, so the net result is a massive spike in blood pressure.
Ah, okay. But if the patient is on an alpha blocker...
You've removed the alpha effect from the equation entirely. The vasoconstriction is disabled, so when you give them the epinephrine, the only doors left unlocked for it to open are the beta-2 receptors.
The ones that widen the pipes?
Yes. The vasodilation is suddenly completely unopposed. So instead of a massive spike in blood pressure, the patient experiences a severe drop in systemic blood pressure. It reverses the expected outcome entirely.
That makes so much sense now. But the sources point out a huge problem with these heavy-duty, non-selective blockers like phenoxybenzamine. When you force the blood vessels open that wide, your body panics.
It really does.
It detects the massive drop in pressure and triggers something called reflex tachycardia. The heart just starts beating dangerously fast to try and compensate for the wide open pipes.
Yeah, that's the body's compensatory mechanism at work, and it's exactly why pharmacology had to evolve, If phenoxybenzamine is a shotgun, medicine needed a sniper rifle.
Okay, so if the heavy-duty shotgun approach makes the heart freak out, how do you fix the blood pressure without causing that reflex? Like, is there a more targeted way to do this?
There is. That's where we get into the selective alpha-1 blockers. Drugs like prazosin, terazosin, and doxazosin.
Doxazosin, right?
Interestingly, doxazosin is unique among them because it has the longest duration of action and is excreted primarily in the feces, while the others break down into inactive products in the urine. But their real value is precision.
Because they only hit the alpha-1.
Right. They specifically target the alpha-1 receptors, decreasing peripheral resistance and lowering blood pressure without triggering those massive, dangerous spikes in heart rate.
Okay, but let's think about this practically. If I'm taking a pill that physically forces all the blood vessels in my body to suddenly relax and open wide away, what happens the exact second I stand up from a chair? Normally, my body adjusts so I don't pass out. But if my receptors are blocked, doesn't gravity just instantly win?
That is a highly astute observation, and it's actually one of the most critical clinical warnings associated with these drugs. You are describing exactly what happens. It's called the first dose effect.
So gravity literally just pulls all the blood to your feet.
Yes. Normally, when you stand up, your sympathetic nervous system detects the sudden shift in gravity and instantly fires a signal to the alpha receptors in your legs, telling those blood vessels to clamp down. That shoots the blood back up to your brain.
Right, so you don't get dizzy.
But if you take a selective alpha-1 blocker, that compensatory mechanism is temporarily crippled.
Because the bouncer won't let the signal through.
Right. So the very first time a patient takes this medication, they can experience an exaggerated orthostatic hypotensive response. Their blood pressure plummets upon standing, and it can easily result in syncope, which is just the clinical term for fainting.
Man, you take your very first blood pressure pill. You stand up from the kitchen table to watch your glass, and you just collapse on the floor. That's terrifying. How do doctors prevent that?
It's actually a very simple workaround. To protect the patient from that severe first dose effect, the initial prescription is usually adjusted to just a fraction of the normal amount, maybe a third of the standard dose.
Oh, okay.
And crucially, the patient is instructed to take that very first dose right at bedtime.
Oh, that's brilliant. So when the massive vasodilation hits, they are safely lying down asleep. Gravity isn't even a factor.
Exactly. And by the time they wake up, their body has begun to recalibrate to the new vascular tone.
Now, I want to pivot a bit because what really surprised me in this research is that some of these highly selective alpha blockers aren't even used for blood pressure at all.
No, they're not.
Like, for example, there's a drug called tamsulosin.
Yeah, tamsulosin represents a fantastic leap in specific drug targeting. It targets a very specific subtype of the receptor, the alpha-1A receptor.
And where exactly is the alpha-1A receptor located, if not primarily in the blood vessels?
It is heavily concentrated in the smooth muscle of the prostate and the base of the bladder neck.
So it's not a cardiovascular drug at all. It's a urological drug.
Precisely. Because it is so hyperselective for the alpha-1A subtype, it has relatively minimal effects on overall systemic blood pressure. Instead, it decreases the muscle tone in the prostate and bladder neck, which significantly improves urine flow.
Right.
It's a primary treatment for benign prostatic hyperplasia, or BPH.
But here is where we get to the bizarre medical trivia that I absolutely love.
I know what you're going to say.
The source casually drops the fact that men taking tamsulosin for their prostate can experience a side effect called intraoperative floppy iris syndrome during eye surgery.
Yeah, floppy iris syndrome.
The iris of their eye literally loses its shape and billows around like a loose sail while the surgeon is trying to operate. How on earth does a prostate drug make your eyeball floppy?
It sounds like a total glitch in the matrix until you look at the underlying biology, you know?
Okay, explain it to me.
The iris of your eye has tiny radial smooth muscles, the dilator pupillae that pull the pupil open. Well, it turns out those specific eye muscles are controlled by the exact same alpha-1A receptors found in the prostate.
No way.
Yes. So when you take tamsulosin to relax the prostate, it perfectly blocks the receptors in the eye as well. The dilator muscle becomes temporarily paralyzed.
Oh, wow.
So if an ophthalmologist goes in to perform cataract surgery, the iris has zero muscle tone. It just flops around in the fluid of the eye, which makes the surgery incredibly difficult.
That is fascinating. It just proves that you really can't alter one part of the body without it echoing through the rest of it.
Right.
Speaking of which, the text briefly mentions yohimbine, an alpha-2 blocker derived from tree bark.
Oh, yohimbine, yeah.
Yeah, it's used for Raynaud's disease to stop the extremities from losing blood flow. And historically, it's been used as an unproven sexual stimulant. It really highlights how ubiquitous these alpha receptors are.
They're everywhere.
But if the alpha blockers control the pipes, we need to move up the chain. What happens when the heart itself is the problem?
Well, that brings us to the beta blockers. If the alpha blockers open the pipes, the beta blockers slow down the pump. And all the clinically available beta blockers are competitive antagonists.
And you can always spot them on a prescription pad, right? Because their generic names almost universally end in -ol.
That's the naming convention, yeah. Propranolol, metoprolol, atenolol. Propranolol is kind of the classic prototype. It is a non-selective antagonist, which means it binds with equal affinity to both beta-1 receptors and beta-2 receptors.
Okay, let's break down exactly what that does to the heart.
So by blocking the beta-1 receptors specifically located on the heart, propranolol effectively diminishes cardiac output. It alters how the heart muscle physically behaves.
Okay.
It reduces the actual physical squeezing force of the muscle, what we call a negative inotropic effect.
So each heartbeat pumps slightly less aggressively.
Exactly. And simultaneously, it slows down the rhythm, the pace of the electrical firing, which is a negative chronotropic effect. It results in bradycardia, a slower heart rate.
So it's literally turning down the master volume dial on the heart.
That's a great way to put it.
It makes perfect sense why this is a miracle drug for someone with angina, where the heart is starved for oxygen or for preventing secondary heart attacks. But, I actually know someone who takes propranolol, and she doesn't have heart problems.
Oh.
Yeah, she's a classical musician. She takes a tiny dose before big recitals, and she says it completely cures her stage fright.
Ah, yes. That is a very common off-label use. It's popular among musicians, public speakers, and even surgeons. And it comes back to the receptors.
Right.
When you get nervous, adrenaline floods your system. That adrenaline hits beta-2 receptors in your skeletal muscles, which causes the physical manifestation of anxiety, the shaking hands, the tremors.
So by taking propranolol, she's blocking the receptors in her hands. Like her brain might still feel anxious about the performance, but her hands are rock steady because the physical panic signal is muted.
Exactly. The physiological feedback loop is broken.
That's amazing. But looking at the mechanics here, I see a glaring, potentially lethal danger.
Which is?
You said propranolol is non-selective. It hits beta-1 in the heart, but it also hits beta-2. If beta-2 receptors are in the skeletal muscles, where else are they? Aren't they in the lungs?
Yes. Beta-2 receptors are heavily concentrated in the bronchiolar smooth muscle of the lungs.
So if you block them, you are turning off the lungs' ability to stay open.
You are hitting on a life or death distinction here. Normal adrenaline keeps the airways wide open so you can take in more oxygen during a fight or flight scenario. If you give a non-selective beta blocker to a healthy person, it's usually fine.
Right.
But if you give propranolol to a patient with a respiratory condition like asthma or COPD, it causes immediate bronchoconstriction.
The airways completely spasming close.
Yes. The text explicitly warns that death by asphyxiation has been reported in asthma patients who are inadvertently given this drug. It is an absolute contraindication. You might be saving their heart, but you are suffocating them.
That is terrifying. And the danger isn't just for asthma patients, right? Diabetics are at risk too.
Yes, that is the second massive risk population. Beta blockade heavily interferes with glucose metabolism. It decreases glycogenolysis, which is the body's breakdown of stored sugar into the blood.
So if a type 1 diabetic takes insulin and their blood sugar drops dangerously low, normally their body would panic and release stored sugar to save them. But the beta blocker stops that from happening.
It stops the chemical counterregulation, yes, but it does something even more insidious. It masks the physical warning signs.
What do you mean?
Think about how hypoglycemia feels. A racing heart, tremors, extreme nervousness, those are all sympathetically mediated signals.
Look, those are the exact same signals we just said the musician blocks for stage fright.
Precisely. The beta blocker turns the volume down on the panic response. So the diabetic patient wouldn't feel their heart racing, they wouldn't get the tremors.
Wow.
They would have absolutely no physical clue that their blood sugar was crashing toward a coma until it was too late.
So you have a miracle drug for the heart that is basically a loaded gun for asthmatics and diabetics.
Yeah.
How did medicine solve that? I mean, you can't just leave their heart conditions untreated.
Right. The solution was pharmacological evolution. Researchers developed cardioselective beta-1 antagonists.
The sniper rifles for the pump?
Exactly. Drugs like atenolol, metoprolol, and acetolol. At standard therapeutic doses, these drugs preferentially target only the beta-1 receptors in the heart.
So they slow down the heart rate, but they completely ignore the beta-2 receptors in the lungs and the skeletal muscles.
Right. They eliminate the unwanted bronchoconstrictor effect. Now, it's worth noting that if you give a massive dose, that selectivity is lost and it will spill over into the lungs. But generally, these are the safe, preferred agents for hypertensive patients who also suffer from asthma or diabetes.
Okay, so we've mapped out the alpha blockers and the beta blockers. But any good biological system has its rule breakers, and these sources outline some wild extremes.
They really do.
Look at a drug like timolol. It's a non-selective beta blocker, but it's not given as a pill. It's given as an eye drop to treat chronic open-angle glaucoma.
Yeah.
It literally blocks the beta receptors in the ciliary body of the eye to stop the production of aqueous humor, the internal eye fluid, which drastically lowers intraocular pressure.
And on the opposite end of the spectrum of extremes, you have the half-lives of these drugs. You have a drug like esmolol, which has a hyper-short half-life of only about 10 minutes.
10 minutes. If it's gone in 10 minutes, what is the clinical value of that?
It's invaluable in emergency or surgical settings. If a patient is undergoing surgery and suddenly develops an acute arrhythmia, the anesthesiologist can use esmolol to immediately, precisely dial down the heart rate.
Oh, I see.
But the moment the crisis is over or the surgery ends, the drug metabolizes and vanishes. The patient isn't sluggish for the rest of the day. Contrast that with a drug like Notalol, which has a massive half-life of up to 24 hours for long-term management.
But the real contradiction in the text, the thing that really made me scratch my head, is this concept of partial agonists.
Oh, I see.
Yeah, the sources talk about drugs like pindolol and acetbutalol. They are classified as blockers, but the text says they possess intrinsic sympathomimetic activity, or ISI. That literally means they stimulate the receptor. How can a blocker be a stimulator?
It is a brilliant physiological paradox. Drugs with intrinsic sympathomimetic activity are not pure antagonists. They do actually have the ability to weakly stimulate both the beta-1 and beta-2 receptors.
So they are pressing the gas pedal.
Let's use a different analogy. Think of it like putting a mechanical governor on a sports car. The drug sits in the driver's seat and drives the car at a steady, unchangeable 15 miles per hour. It's weakly stimulating the engine. It refuses to let the car stop completely.
Okay.
But here is the crucial part. Because the drug is occupying the driver's seat, the actual race car driver, the massive rush of adrenaline, cannot get into the car and floor it to 100 miles per hour.
Ah. So it forces a low idle, but absolutely prevents the system from redlining.
That is exactly what it does. The net effect is a highly controlled, diminished cardiac rate compared to the wild swings of natural adrenaline.
That's so clever.
But because it's providing that weak baseline stimulation, it is incredibly useful for hypertensive patients who already have moderate bradycardia, like a naturally slow heart rate.
Because if you gave them a pure blocker, their heart rate might drop too low and stop.
Right. The ISA drug protects them from the adrenaline spikes without causing the extreme resting slowness of a pure blocker.
That is incredibly elegant. And it leads perfectly into our last group of combo breakers. Let's talk about carvedilol and labetalol.
Carvedilol and labetalol are fascinating because they are dual antagonists.
Hang on, carvedilol, labetalol. Notice they don't end in olol like the rest of the beta blockers. Did the pharmacologist break the naming rule on purpose?
They did, because the drugs break the functional rule. They aren't just beta blockers. They block beta adrenoceptors, and they can currently block alpha adrenoceptors.
The ultimate combination tool. So you get the peripheral vasodilation, the opening of the pipes from the alpha blocking side, and you get the heart rate control from the beta blocking side.
It solves the exact problem we discussed at the very beginning. Remember how if you just use an alpha blocker to open the pipes, the body panics and triggers reflex tachycardia? The heart starts racing dangerously?
Yes, the shotgun effect.
Carvedilol and labetalol bypass that entirely. The alpha component opens the vessels to drop the pressure, and the beta component simultaneously holds the heart rate perfectly steady, preventing the panic reflex. It is so effective that carvedilol has been shown to significantly reduce mortality and hospitalization in patients with chronic heart failure. And labetalol is widely used as a safe, effective alternative for treating pregnancy-induced hypertension.
Everything we've discussed so far has been about playing defense. We are putting bouncers at the club door, intercepting the chemical messengers right at the receptor. But the final section of our sources introduces a completely different strategy. Hacking the source.
Yes.
What if we stop the chemical messengers from ever leaving the nerve terminal in the first place?
This represents a massive mechanical shift in pharmacology. We are moving from drugs that block the target organ to drugs that infiltrate and affect the adrenergic neuron itself. They physically interfere with how the neuron stores or releases neurotransmitters.
The source talks about a drug called reserpine. The mechanism is wild. It blocks the transport of biogenic amines like dopamine, serotonin, and norepinephrine from the cytoplasm of the cell into the storage vesicles.
Imagine the nerve terminal is a factory, and the storage vesicles are the delivery trucks. Reserpine essentially barricades the loading dock.
Okay.
The neurotransmitters are manufactured, but they can't get into the delivery trucks to be stored safely.
So what happens to them?
They just pile up outside on the factory floor where cellular enzymes eventually destroy them. Over time, this causes an absolute, complete depletion of these amines in the nerve ending.
They're just totally gone.
Yeah, the entire sympathetic function shuts down simply because there is nothing left in the inventory to release. It has a very slow onset, but the effect persists for many days after the patient stops taking it because the neuron has to slowly rebuild its entire stockpile.
And then there's guanethidine, which acts slightly differently. It doesn't block the loading dock. It actually shuts the garage doors so the delivery trucks can never leave.
Yeah.
It blocks the release of the stored norepinephrine entirely. But I have to pause here. I was reading through these highly technical descriptions of blood pressure medications, glaucoma treatments, and heart failure drugs, and suddenly, sitting right next to guanethidine in the chapter, is cocaine.
Ah, yes.
Why is a highly addictive, illicit street drug sitting in the middle of a cardiovascular pharmacology text?
Because cocaine is fundamentally a sympathomimetic blocker, but it doesn't block the adrenoceptor on the target organ. It blocks the reuptake mechanism on the presynaptic nerve terminal.
Explain the reuptake mechanism.
Normally, when a nerve fires, it releases neurotransmitters like dopamine or norepinephrine into the microscopic gap between cells called the synaptic cleft.
Right.
The dopamine binds to the receptor, does its job, and then detaches. But your body is incredibly efficient. It doesn't want to waste that dopamine. So the original nerve has a vacuum pump, a monoaminergic reuptake transporter that sucks the dopamine back up to be recycled.
It's the cellular cleanup crew.
Exactly. Cocaine binds directly to that vacuum pump and paralyzes it. The cleanup crew is locked out.
So the dopamine is fired out, it does its job, but it can't go back home.
It is trapped in the synaptic space. It just sits there, continuously bouncing against the receptors over and over again, massively amplifying the signal. In the limbic system, which are the pleasure centers of the brain, this continuous trapped dopamine bombardment produces an intensely powerful euphoria.
But because it's trapped outside the cell, doesn't it eventually get destroyed, just like with reserpine?
Yes, and that is the biological tragedy of addiction. Because the dopamine isn't being recycled, the brain's finite stores are rapidly exhausted.
So they just run out.
Yeah, this chronic, absolute depletion triggers the vicious cycle of craving. The user physically requires more of the drug just to temporarily relieve the severe, crushing depression caused by having absolutely no dopamine left in the system. It perfectly illustrates how tampering with these delicate chemical feedback loops can have catastrophic neurological consequences.
Man. So let's step back and synthesize this. We started with the sheer brute force of phenoxybenzamine, supergluing receptors shut to protect a patient from a rogue adrenaline-pumping tumor.
Yep.
We saw a treacherous first-dose effect of selective drugs like prazosin, where a single pill can drop you to the floor if you aren't safely in bed.
We learned how modifying a molecule slightly can create a highly targeted tool like tamsulosin, specifically relaxing the prostate without crashing your systemic blood pressure.
And we looked at the beta blockers, discovering how turning down the master volume on the heart can be a miracle for a heart attack survivor or a musician with stage fright, but a lethal trap for an asthmatic if the wrong receptor is hit.
Exactly.
We explore the brilliant paradox of partial agonists acting as mechanical governors. And finally, we saw how hacking the actual storage and reuptake of these chemicals explains both the methodical depletion of nerve signals and the tragic biological cycle of cocaine addiction.
The overarching theme of this deep dive is just the breathtaking precision and consequence of the autonomic nervous system. It is an infinitely complex, perfectly balanced web of feedback loops.
It really makes you appreciate your own biology on a minute-to-minute basis. I mean, every single time you stand up from a chair, your blood vessels instantly tighten and your heart perfectly adjusts its rhythm, all in fractions of a second, just to keep gravity from making you pass out.
It's pretty wild to think about.
It is an incredibly delicate, microscopic dance of alpha and beta receptors happening in real time every second of your life.
Which leaves us with a fascinating thought to ponder, really. We have clearly mastered the pharmacological ability to artificially mute the body's physical panic responses with incredible precision. Selectively lowering blood pressure without slowing the heart or steadying the hands without closing the lungs.
Right.
As our mapping of these neural pathways deepens, how much further can this go? Could future pharmacology allow us to completely seamlessly untangle our physiological reactions from our psychological stress?
Imagine a world where that big red fight or flight button is entirely, consciously under your control. Until then, stay curious and thanks for taking the plunge with us on this deep dive.